Welcome back to Module 1B, Prevention Education for the Undiagnosed. As we do for the top of each module, we are going to hear from some of our friends. So let's start with our first voice.
I don't know that we can totally tell our doctors and nurses and other medical professionals how they have to behave if it's outside of their realm of who they are. So part of the strength comes from knowing the resources that are around you. And if you are not capable to provide whatever this patient needs, being able to say to them, you know, you can go to Chicago Recovery Alliance and they can talk to you about vein care or harm reduction. You're out in the suburbs, you can go to Live for Lolly. I'm not comfortable with that. It's fine for a medical professional to say, I'm not comfortable for that, that's out of my realm, but I know people that can help you.
I think that's really wise words from Laura, and ensuring that we work within our own boundaries, but ensuring that we meet people where they are to refer where appropriate. Now I want to say with Peter, the question I asked him were, could people use drugs safely? And this was his answer.
Available and accessible, then yeah, people can. Doesn't mean that some people aren't going to OD and some people aren't going to get in trouble otherwise. But I think the humane thing to do is to really, when we talk about meeting people where they're at, is to be there at that space where they're at that time, and to listen to them and to provide them what they need just to stay as healthy as they can.
Thank you, Peter. We'll hear from...
The nature of reality is, my deep truth is, we do recover if we survive long enough. Mm-hmm. And if we survive long enough, I think it would be ideal for people not to have lifelong complications because they were using drugs previously.
And finally, we'll end with Luke today.
As far as things that have worked for me now, I don't like I like being human. I think that, for so long, I was a familiar face in a small town, so for so long I hid my use and I was just underground. I worked as a tech director at a grade school. I was just a public figure. I was active with the March of Dimes. And I think, I guess what worked for me was being honest, being open, not feeling like I had to hide anymore. It took a while for me to come forward with my story, just because I was always made to feel like I was a criminal. But the thing that is important is this isn't criminal behavior. A majority of adults and children experiment with drugs and alcohol at some point in their lives. And, it's human behavior. It's not criminal behavior. So I think being able to humanize who I was as a person and not be ashamed of it was very important.
So thanks, Luke. I think you're going to hear a lot of through lines from what our folks just talked about and what we're going to be discussing through the slides. So one thing I want to talk about before we jump into what harm reduction is, talking a little bit about what substance use treatment in our country has typically looked like and how we approach it. And typically, we've approached it through an abstinence-based model where we expect people to abstain, what we've often called sobriety, and ensuring that they never use drugs again. And I look at that as a very black and white model. You're either using drugs in that case or you're not using drugs in that case. But there's another way to look at this, which is much more of the gray scale. And that's where I believe harm reduction comes in. And we look at it that, hey, if you're going to use drugs, why don't we work it so that we can reduce your harm and make it so that, just as Alex talked about, we can reduce any lifelong complications that might ensue as a result of drug use. Some of what's important in these tenets, you heard Peter talk a little bit about this, meeting people where they are. We talked about Luke saying he likes to be referred to as a human. These are all pieces that I believe are part of what we can include in harm reduction services to help someone meet the recovery goal that is appropriate for them. And one thing I used to hear Dan speak over and over, and is certainly the motto of Chicago Recovery Alliance, is any positive change. And what that means is that if someone is using, let's use the case of alcohol in this case, let's say that someone's drinking 5 beers a day. Our goal would be to see any positive change for that person. Maybe they go down to 4 beers a day, or maybe they intersplice water between each of those drinks. So as we talked about in terms of the spirit of the way that this training is built, is this concept of nothing about us without us. In order to see change, we ultimately need to include the folks that we're working with and for. One of the components of harm reduction that is a little bit different than what we'd see in your typical abstinence-based treatment is that relationships are certainly at the center of this harm reduction approach, and that the helper, in this case, their priorities are way less important than that person that we're serving. And that person that we're serving is there to guide the ship and dictate ultimately where those harm reduction services should be geared to. And so with that, I heard Luke talk a bunch about being open and being honest and wanting to be referred to as a human and not a criminal. And that's one piece that I think is vital to addressing substance use and the way in which our country works with drugs, is making sure we use conscious person-first language. I know I hear so often we talk about a substance abuser or a drug user. Where's the people in that? The people who use drugs, a person who once used heroin. And while, yes, this is certainly using more words to describe something that maybe someone that we could use less words in, it is certainly more respectful, and I believe will promote an environment where your clients can be more honest and open with you. One of the huge pieces of harm reduction is educating and empowering our constituents to make the most informed decision that is appropriate for them. People will use drugs no matter what that drug might be, and our goal is ultimately to say, how can we reduce your harm from overdose or from infectious disease acquisition? This promotes this buffet type option where there's different flavors, if you will, of how we can promote quality of life and harm reduction. And this oftentimes comes in the question of not this is what your recovery will look like, but more the question of what would you like your recovery to look like? These are some of the really important tenets of harm reduction that make it drastically different than our typical abstinence-based model. I want to bring in the importance here of language and how this is really it helps to incorporate the essence of what harm reduction is and what it isn't. I believe last year, SAMHSA came out with a paper about the importance of semantics. And I'd encourage you to read that and think about where in your own language or where in the paperwork or systems that are set up in your programs might you want to look to remove or replace some of this value-based language. Going back to Luke and what he said about wanting to be a human, I think about the importance and the weight of the words or semantics that we choose to discuss drug use. I've often heard someone say a drug user or abuser, and those words weigh differently in my mouth than if I were to say a person who uses drugs. And this is important when we talk about facilitating a space where someone feels not judged and not condemned based for the actions that they may have taken, but they are able to come with their whole selves and they'll be treated as that human. One thing I thought was important, this was in discussion I had with Chicago Recovery Alliance as we were building these slides. So often in our culture, we talk about SUDs or substance use disorders. And even that in itself is certainly stigmatizing. And I really liked the concept that they use of substance use management, that we're working to help that person manage their substance use, right? That not really making this something that's stigmatized even further. And so how can we help them manage? Again, I talked about what does recovery look like for you? For some people, abstinence may be exactly what they're looking for. Maybe it's a step down approach. There's various flavors for various people. And again, for those of you who have worked in STI or HIV, you've heard a bit about sex practices that we deem as safe or safer practices. This is the same concept with harm reduction. So it would be safe to use my own works, and it would probably be safer to use my own works in the presence of other people, just to protect myself potentially from overdose. Just really wanting to drive home the importance of choosing your language and avoiding assumptions. This really helps in assisting with rapport building and relationship building, and ensuring that you ask someone to tell them your experience and not just assume that you know what their experience is. One thing I do want to point out is this last point. This was a point given to me by some of the folks that helped in the development of this, but really avoid using the word junkie when referring to someone who uses drugs, even though that client you're working with might refer to themselves that way. And that's okay if they do. This is certainly part and parcel to the stigmatized nature of drug use in our country. So to help visualize this harm reduction buffet, I took these words from Dr. Suzanne Karlberg-Rakic, who is the Director of Research at the Chicago Recovery Alliance, and she's also an assistant professor with the Masters of Public Health program at DePaul University. And I'm going to read this because I thought it was just so beautiful. And this is around a buffet style approach versus the one size fits all abstinence-based approach that's often touted with other types of substance use treatment. The essence of harm reduction is not to have a set of expectations, but to facilitate any number of positive changes in any order, prioritized by the participant. People choose what they want, and it isn't about progression. It's just about mutual respect, relationship building, and a choice of any positive change. And I'm sure if you worked with Dan, this was something that you saw him certainly embodying. And to flesh this out even further, certainly not appetizing, but we've got a salad bar here. And the idea here is we have different ways in which we can serve up a buffet of options for someone to reduce their risk. Maybe they manage their risk through MAT or OAT. They address their wound care or their abscess care. Maybe they're engaging in services. Maybe they're changing their use consideration and thinking about how I might be able to use something in place of or differently or less than. A ritual or preference change and this radical non-sharing. Maybe using condoms or getting tested or engaging in syringe service programs. So you get the idea here of offering up a buffet of options. And I know even just with the way that Live for Lolly or the Chicago Recovery Alliance does their harm reduction outreach, it is a buffet style. You walk onto the van and it's kind of take what you need in a buffet format, which certainly helps reduce any assumptions on what someone might be coming in for. So something that's really important that we talk about is some misconceptions that are pretty common amongst folks in our country about harm reduction. I've talked to countless people who haven't even heard of the term harm reduction, and those who have typically worked in some abstinence-based programs. I've heard a lot of these misconceptions that people who work in harm reduction, they lack boundaries, or that by providing needles or clean works, you're actually encouraging drug use, and that ultimately people who use drugs lie. And these are really important things to address here. And in terms of the lacking of boundaries, I would really beg the question of whose standards or model of care are we talking about with these boundaries? There's a ton of research out there to disprove the fact that harm reduction encourages drug use, and it doesn't. Syringe service access does not increase drug use, and there's great research out there to show that. This one misconception that people who use drugs lie, I'd like to kind of break this apart, especially as we talk about relationship building and understanding the impact of culture on our behavior. Because we've lived in a system, in a culture where there's been a war on drugs for years. And ultimately, what this war on drugs has set our culture up to believe is that people who use drugs are bad, and wrong and criminal, and that ultimately we need to punish them for their behaviors. But ultimately, this is a system level failure that we have set up to enforce and reinforce people who use drugs to lie in order to actually be able to survive. Because but for them lying about their drug use, they will risk, just as I have here, losing their home, maybe custody of their children, maybe even getting access to employment, and certainly risk of reincarceration should they, maybe in this case, someone who's on probation, smoke marijuana and lie about it. This is a vital thing for us as workers to understand that our system has been set up to reinforce people to lie. And by knowing this and encouraging a place where our constituents can tell the truth and not feel judged or condemned, this will help to build your trust and rapport over time so that you can really help them stay alive. Maybe it means using safely so that they don't overdose or acquire an infectious disease. And this is a vital piece, especially knowing that our culture condemns and judges people who use drugs. Lastly, I've heard a lot of people say, well, if we use MAT, medication-assisted therapies, or OAT, opioid-based assisted therapies, that we're just replacing one drug with another. And what I want to say to that is, yep. Isn't that the same as what we would do for our patients who have diabetes or are depressed and unable to work? We give them an antidepressant or insulin to help control these things. And what MAT ultimately does from a pharmacological standpoint is it gives that person their life and their brain back so that they're not constantly working in fear to avoid withdrawal. A very painful process. So these are some things that I constantly hear that are vital to dispel as we move forward and certainly talk with our colleagues and our constituents about. So one thing I want to point you to, SAMHSA, the Substance Abuse Mental Health Service Administration, puts out these things called TIPS, Treatment Improvement Protocols. And there are a number of them that ultimately address various issues as it relates to substance use and treatment. This one in particular, I want to point you to TIP 63, which is around opioid use and medications to help treat that. They have a really great exhibit 1.2 that compares the different medications used in opioid agonist therapies for OAT or medication-assisted treatments. There's three things that we have three different drugs that we use: methadone, buprenorphine, some of the trade names we've heard, and naltrexone we've heard, Vivitrol, and Suboxone. But these drugs will do one of three things, which is reduce or eliminate the withdrawal symptoms that someone who uses opioids might experience. It might blunt or block the effects of using an illicit opioid. So if they took this medication and then were to use, say, heroin, they would not feel the effect of that. And it reduces or eliminates the cravings to use opioids, allowing this person that freedom to move forward with work or whatever the situation might be. And I'd also like to point out that the impact, and we're not talking about Vivitrol, otherwise known as naltrexone here, but methadone and buprenorphine both, we see a positive impact here in terms of reduction in fatal overdose and all-cause mortality. This is a huge public health and a vital intervention for people who are dependent on opioids. Let's talk about a few more things to keep in mind. I just talked about those who are dependent on opioids. And I constantly hear our culture mix up this difference between addiction and dependence, because they are very different. You know, we'll hear people say babies are born addicted to drugs. And that's just untrue. They may be born dependent to drugs, which talks about a physiological body-based reaction to a specific drug or medication. But addiction comes with, yes, that dependence, but a whole set of behaviors that are part of this person's life to acquire a drug, and oftentimes addicted to various components of medication and behaviors, and really different when we talk about how we treat dependence versus addiction and lifestyle. One thing to keep in mind as well is that oftentimes the local story that you might experience in your city or even state might be different than what we hear about on a national level. I know that nationally, we've been talking about opioids, and it's really come to the forefront, especially as we've seen young, white, suburban youth be clobbered and taken by overdose. And that story of that young, white suburbanite is really different than, say, in Chicago, what we're experiencing. Because the local story here in Chicago is, heroin has been an issue in our south and west sides of Chicago for years and years. And so it's important to remember that nationally, what's going on is really different than how and why opioid use disorders or the issues related to them are coming and bubbling to the surface. A few other things to keep in mind here, I really, in terms of number 3 through number 7, the vein care and safer injection, Heimer's research, using lotion and lip balms and buddy systems, these are all things, and accountability if using alone. You'll be able to find more information on the Chicago Recovery Alliance, who really goes into the nooks and the crannies and all of the nuances of what this is about. And ultimately, this buddy system piece is really huge, that if I'm going to use, maybe I want to have some accountability, let someone know that I'm using, just to go ahead and keep myself safe, especially in a time where our drugs are often laced with fentanyl and other fentanyl analogs that are killing people. And I highly encourage you to check and reflect on any personal biases that you might have and how this may come out in your everyday language, because all of us have been raised in a culture where the war on drugs has ultimately run the show and taken over. And it has tainted and socialized us around what substance use and substance use disorders are and are not. Certainly has perpetuated stigma and also contributed to the biases that each of us might have. So highly encourage you to continue discussing and getting uncomfortable with some of these things and being comfortable with the fact that some of this is uncomfortable to discuss, and that's okay. In terms of prevention and education for Hep C, those who are undiagnosed, we're setting each of these modules up on what's changed as well. And one of the huge things that's changed within the past few years is access to syringe service programs around the country. The CDC vulnerability assessment, I believe that came out in July of 2018. And this was a national assessment that the CDC did and identified, this report identified 220 counties that were vulnerable to infectious disease outbreaks, ultimately syndemics at play from what we talked about at the top of this presentation. It identified these counties that had these vulnerabilities, giving them access to more opportunity for harm reduction services and implementing those harm reduction services. So it's this assessment has opened the door for more states to take action and figure out how they're going to do something about being able to offer harm reduction services. We've certainly seen an increase in Hep C and overdose and fatal overdose, as we know, much of which is related to fentanyl and what is inside our drugs. I have certainly seen the attitudes towards people who use drugs change. And I think that while this is certainly a politicized and oftentimes very much a racialized issue, there's certainly, I've seen areas where we're able to talk more about ways in which we can treat opioid use disorders and other types of substance use disorders. I've seen this, if nothing else, just in the acceptance of more harm reduction models and really understanding what these models are and what they aren't. And I've also seen, and again, I do want to keep in mind that some of the reason I've seen this could just be the company that I'm keeping, but I have certainly seen situations that the attitudes of people who use drugs have changed in regards to oftentimes feeling less stigmatized and willing to come out about their story and share and be peer supports, which is is how change happens. And I think that that's a really vital piece to changing the conversation around drugs. And so supporting and encouraging honesty and non-stigmatized language, I think, can help build up people and their own personal attitudes around drug use. Naloxone and availability and distribution of naloxone has changed dramatically. You know, Dan contributed a ton to this over the years in his work. Definitely seen Live for Lolly help in our state in Illinois, do a lot of work with access to naloxone. And certainly, both for good and bad outcomes here, we've seen an increased commercialization of methadone and access. Oftentimes we see this as for cash businesses and not necessarily there to always support the individual. Let's talk a little bit more about what's changed. And I want to talk a little bit more specifically. These two slides are from the CDC, from a study done over a decade. And this is related to hepatitis C and drug use. You know, one thing I want to point out here on this slide here, so this one is around younger Americans, which we're deeming that 18 to 39. And we'll see here this dark orange line is any opioid injection amongst 18 to 29-year-olds. And the white line is any opioid injection amongst 30 to 39-year-olds, so the older of that cohort. The dotted orange line is Hep C, the rate of Hep C amongst that younger group, and the white dotted line is Hep C rates amongst that older group. And so we'll see, obviously, there's been a huge increase of about 400% hepatitis C increase over that decade amongst that younger group, 18 to 29. And alongside that, we've seen around that same group an admission for opioid injection increase 622% over that decade. Well, amongst people 30 to 39, again, this white line, hepatitis C has increased by 325%, and admission for opioid injection has increased by 83%. And the point I want to make here now is that what we know to be true is that of the people that would like or who require substance use treatment, only a small proportion, and usually about 10% of them or so, actually get access to that treatment. And so this says a lot in terms of a huge increase of 622% and 83% amongst these groups. Those are just of the people who have gotten access to treatment, not those who wanted it and weren't able to get it. Let's take this a little further. This is hepatitis C and opioid injection among women from 24, same decade here. And we saw this orange line is the Hep C rate of women, and the white line is any opioid injection among women. And obviously we'll see they're both increasing naturally, understood that Hep C would then increase by 250% in that decade. And for this group, admissions for opioid injection increased by 99%. So I want to think back to and take you back to our syndemic slides, right? And so naturally, if we're seeing women, these of which are women of childbearing age, having an increase of Hep C, we're going to have more children born to Hep C infected mothers, which is perfect time for us to test folks when they're young, certainly, and when they're pregnant, which we will go into more in the next module. So I want to take this information of what's changed and make it a little bit more granular. And we talked about nationally were those last CDC slides. I'm going to take this into Chicago and the United States. This is research that I'm referencing from Dr. Elizabeth Salisbury Afshar, who works for the Center for Addiction Research and Effective Solutions at the American Institute for Research, based in Chicago, and did a good amount of work as well with, again, Dr. Suzanne Karlborg-Raking. And what we're seeing here is this is opioid overdose death rate by age in the US in 2017. What we see here, the red bar is US and the blue bar is Chicago. And so what we see here is that the 25 to 34-year-olds are dying at the largest amount in the United States, as you see here represented in the red bar. But in Chicago, the 45 to 54-year-olds are more than 3 times almost dying by overdose death rates than the national picture. And this is really important when we think about the money that is coming down and trickling down to states and counties from the federal government. And oftentimes, as we were talking about, that federal picture is different than what's going on locally. And so how are we able to take the funds that are trickling down based on national trends? How are we able to use that to address what's going on more locally to our own picture? And I encourage you to look at your own city and state and how you're matching up to the larger national picture as well. So this is from the same research by Dr. Salisbury-Afshar. This is about opioid overdose death rates by race and ethnicity. This was in 2017. And nationally, you'll see whites are dying by overdose death rates at the largest proportion. But in Chicago, we're seeing non-Hispanic African Americans dying at the highest rates. So again, just pointing out and encouraging you to see how does your local picture match up or not with what's going on nationally, and how the national dollars are then influencing the way in which you're able to do your work at home. We're getting to the point of our module where we reach tools and resources. This is a really important point. You'll be able to catch this on our Module 1 webpage. Down below, you'll see that there's links to all of these resources, and I highly encourage you to look at them. There's the Chicago Recovery Alliance and Live for Lolly. We've got our outreach sites, and there are countless harm reduction programs around the country that have their outreach schedules as well. I encourage you to look there. I would encourage you to look at how Ryan White programs, which naturally are a vital piece to our public health infrastructure as we talk about HIV and STI prevention. I would think about how you can use the funds for hepatitis C testing and prevention. Again, I'd encourage you to look at the SAMHSA tip manuals. The link that's provided there will take you to their store, and read through all of the various tips as it relates to substance use disorders. You can download them as a PDF or order them hard copy. I'd encourage you to look at your state dollars. In Illinois, the state substance use program department we call SUPRA, now certain SUPRA dollars. I would encourage you to look within your state what that department A is called, and B, how they are funded and what funding is available for syndemic programming for screening, testing, and prevention. I'd encourage you to look. There is a link for nationally what MAT providers are out there, because we know that there is a dearth of providers who are willing to provide MAT. But there are a number of federally qualified health centers who are treating, not only testing, but treating for hepatitis C. There are links for clinical trials where you might be able to access free research for your constituents, and this might be a good place for some folks. I'd highly encourage you to look at some of the harm reduction coalition toolkits that we've provided. And also, for those of you who are familiar with ECHO, I'd encourage you to access that. For those of you who have not heard of ECHO, ECHO is a telehealth platform that's been around for quite some time. ECHO stands for Extension of Community Health Outcomes. And this was started with Dr. Sanjeev Arora in New Mexico. And actually, while there are ECHO telehealth sessions for almost any or every disease state at this point, ECHO was actually built around hepatitis C treatment. Dr. Arora is a hepatologist in New Mexico, as I mentioned, and if you haven't been to New Mexico, there is certainly a bunch of rural area there. And what Dr. Arora was finding was that he was getting his patients coming in and driving many, many hours to come have a specialist appointment with him, only to not have their home physicians run the correct tests for that patient to actually utilize that specialist consult session with Dr. Arora. And they were wasting time and resources by not having ultimately the education and the information that they needed. So Dr. Arora built this ECHO, and his concept here is to move knowledge, not patients. And so he trained physicians in their hometown on how to test and treat hepatitis C, and they were getting the same outcomes as if Dr. Arora had done it in his office. And so this is something that's, you don't have to leave your home, and certainly in the time of COVID, we're all home. Many of us are home, certainly, and get access to other telehealth services. So there are ways that you can get training and even get CEs for them for hepatitis C and opioid use disorders. You can access the University of Chicago, which I know has an ECHO hub here in Illinois, but this is certainly available across the country, and you don't need to live in Illinois or Chicago to access the University of Chicago resources. So all of that to say, ECHO is a great tool, especially in the way in which we will provide public health post-COVID or with COVID. So one thing I want to talk about here, and getting a little bit into homework, if you will, or some exercises to help you envision a bit about where you'd like to take your hepatitis C program. So there's a few pieces here I want to discuss. You will be able to download these tools on the resource page on Module 1, but I want to make sure that we go over them so you can see how to utilize this information to integrate programs into your existing infrastructures. So what I've done here is you see this spectrum of care that the cascade that we talked about of being undiagnosed and diagnosed. We stage someone, treat someone, cure someone, and there's wellness for hepatitis C. What I would like for you to do is think about your program. Many of you work in programs that are more on continuums, which would be probably, if we were to think of the model, it would be more of a circle. And others of you work in more cascades that would look like this. Regardless, I'd like for you to think about your system and your program as a cascade. And I would like for you to fill out the program process and flow into each of these boxes. I'm going to illustrate this a little bit more for you. This is what the visioning tool looks like. You'll be able to download this, but I have filled it out for the purpose of an example here. So you'll see we've got our cascade up here. And I use this example from when I worked at an addiction treatment facility. This was in 2013-ish. And what I did was I took our continuum of care and I made it into a cascade, and it kind of looked like this. The program that I was in, we would provide outreach services to those in the community. Those who were interested could come in for detox services. If they were to finish their detox, they would have opportunities for residential treatment on site. In this residential treatment, this time was variable for that person based on their level of care or comorbidities, if they were incarcerated or not, were they pregnant, a host of things that would ultimately determine how long this residential treatment would last. But from there, they'd be able to go into a recovery home, which again was on site, and again, variable time based on a host of different issues. While they were in their recovery home, they could attend outpatient treatment on site. And from there, they would be able to get into recovery on-site housing. And so as you can see, this was sort of, if I were to break up, hopefully nobody would relapse and have to come back into detox. But I was trying to make our continuum of care a cascade. And what I noticed was that they actually lined up really beautifully, that if I had a magic wand and I could make everything the way that I wanted it while I was in that program, I would go into the community and I would work with people who didn't know if they had Hep C or not. And they would have risks, and they would certainly have substance use disorders that they would like to get into treatment for. So I'd bring them in, and while they were in detox, we'd be able to offer them a test and we could diagnose them. And we would basically be able to say, hey, not only are you managing the substance use disorder, but you've got this infectious disease. So let's actually get you into treatment and for managing substances and for managing your Hep C. So we would diagnose them and get them into residential treatment. And while they're there in that residential treatment, we'd go through this whole process of staging them. And in Module 4, I believe, we'll be covering what that is. And so we'd stage them while they're in treatment and tee them up. So once they get into this recovery home, we could treat them. And then we would cure them while they're in outpatient treatment. And this is perfect because they've got this 24-hour care and management right there to ensure medication adherence. And then once we would get them well and be able to manage either preventing reinfection or managing their advanced disease, they'd be in their on-site recovery housing. And so this was my magic wand scenario that I was really hoping for. And so this was vital for me to understand what services should go where and how we could integrate this model into services that are already existing. So what I'm going to encourage you to do is let's look at this third row, these squares. And these squares are ultimately what you have, the haves and the resources at your disposal. I knew that we had rapid tests and educational items, which were vital for those who were providing outreach services. It was important for me to provide rapid testing and confirmatory testing, which we'll go over next module. And we also had transportation, which was really important for those who were in detox. We had this referral to on-site care. We could provide people with laboratory and the transportation. We had relationships with pharmacies. This was vital to provide staging for my folks who were in residential treatment. Along with those relationships and the transportation resources, we were able to provide 24-hour monitoring and reminders for those who were in the process of their Hep C treatment and in a recovery home. We had in-house support for those who wanted cure, and they could do peer education. And within the peer support, prevention, and MAT were the folks who were in ongoing wellness and on-site recovery home. And here's some of the things we didn't have, and this is what I'd encourage you to think about the needs. At the time, we did not have a lab or mobile phlebotomy options for syringe service or harm reduction at the time. This would have been great. We weren't funded to provide case management services for those who had Hep C and were kind of in these early stages and what we would call flight risks at this point. How are they, this was a really tentative time of treatment. How can we provide case management for them? Access at the time to fibroscans was difficult, and getting the cure was even more difficult at the time. These are all things that ultimately influence how we're able to provide programming. So I'm hoping that on this blank sheet, you'll download this and you'll be able to take your program and put it into a continuum and see how this lines up with the hepatitis C care cascade. Talk about the haves, what resources you have in your program, and then your needs down below. And for the last activity, this is action planning. And this is something that I would imagine you'd have with you throughout the rest of these 7 modules. Maybe right now you're not exactly sure what action steps or goals or visions you have to develop your program and to further enhance the services available to your constituents. So I'd encourage you to think about maybe 3 action steps that you take, and the what are the actions you might want to see, the who of that action would carry it out. Place a little timeline for yourself on how long that might take, what resources might you need, and how you might communicate that goal or action step. So again, this is also downloadable for you as a PDF on the resources page on Module 1. So we are complete with Module 1. Congratulations. The next module is diagnosis and screening and testing. It will be about an hour. You'll be able to get CEUs for those, and the purpose of that is to break down the various hepatitis C testing options. Again, I want to remind you that this was all based on what I wish I would have known when I started my work in hepatitis C, and now that I'm in and entrenched in the work of hepatitis C, this is ultimately responding to some of the resource gaps that I see continue to exist. Don't forget to take your pre and post tests so that you can get either CEs or a certificate of attendance. And please be sure to access the tools and resources on the Module 1 page. And you can always email us with questions should you have difficulty navigating the page or difficulty finding the resources that we talked about. Look forward to seeing you at Module 2 when we talk about screening and testing in order to diagnose hepatitis C. Thank you.